Our next speaker is a friend from Ochsner. It's Dr. Clark Alsfeld, who's our primary stem cell therapist and cellular therapist. He came to us by way of training from MD Anderson, has clinical and research interest in leukemia, myeloid malignancies, graft versus host disease, cell therapy, and stem cell transplant. So our next presentation is going to be on advancements in treating another sometimes disparate patient population, the older patient with AML.
All right. Good morning, everybody. Thanks for letting me come and chat about advancements in acute myeloid leukemia for older patients. I will start by acknowledging that this might be a sensitive subject for some people. I didn't define the term older. In leukemia terms, they use older as greater than 60. I think about my dad who's 70 going on 21, and I think age is certainly just a number, so please don't shoot the messenger. I have no relevant disclosures. I'm going to start by talking really about our current standard, and I think most of us are very well aware of what our current standard here in the U.S. and across the world is. Identify really some of the challenges that we have with this patient population. Then I'll spend a majority of the talk going over just really some of the newer treatment options that are available for patients nowadays, and then discuss just briefly some of the newer therapies or new ideas that are coming out. So the current standard, as most of us know, is our lovely friend 7+3. It's a wonderful treatment regimen, very effective. I tried to find the initial article and include it in here. Unfortunately, this is the closest thing that I could find to it was the headline for the article. It's because it predates the digital era by a few years. It was published in November of 1973. That's 7 and 3. That's over 50 years ago. And I would wonder what everybody remembers what happened in November of 1973. I certainly don't. I wasn't alive then. But we can go back with Google and kind of touch on some of the current events in November of 1973. So Richard Nixon was president. This was when he okayed the Alaskan pipeline. Billy Joel published his second album. It was Piano Man. I think some of us probably remember that. Reggie Jackson and Pete Rose were both MVPs of the American League and National League. A lot of things really highlighting from 1973 have changed to now. And I think this, to me, really puts it into perspective that 7 and 3 is an incredibly effective regimen, but this slide here really sticks out to me. I think that this is an incredibly effective regimen. This is a study done by MD Anderson, really looking back over the past 50 years. And you can see here, if you focus your attention, ignore the one on the right, just look at the slide on the left, the Kaplan-Meier on the left, we do see improvements, and we do see people living longer. Certainly for 5-year survival, the needle has shifted, and that's probably related to a lot of factors, anything from prophylactic antimicrobials, better supportive care, better transplant options. So we do see with 7 and 3 and some other regimens that there is a movement of the needle. But in my opinion, the biggest problem is when you look at the curve on the right. There isn't the needle moving, and you can see certainly there are some improvements. The 5-year overall survival has improved for patients older than 60, but we're not there yet. And the question is, well, why does that matter? If you look at the median age of diagnosis for AML in the U.S., the average age is 68. So again, going back to that slide before, we're already starting off behind the ball. In patients 65 to 74 who were diagnosed with AML, only 20% of them are going to survive 3 years. In patients older than 75, only 20% survive 1 year. So certainly there is a lot of room for improvement and a lot of need for change in this area. Some of it, of course, is due to patient characteristics. So we do find that patients, as they get older, performance status declines. There's acquisition of new comorbid conditions. So it's a more challenging patient population to treat, and I certainly recognize that. There are also some disease-based characteristics that are different. And we do find that patients in this age range have a higher likelihood of unfavorable cytogenetic abnormalities, more adverse molecular changes. There are multi-drug resistant genes, certainly higher prevalence of secondary AML, all of these highlighting that it's more than just the disease state, it's also the patient population, and really why we have to get creative in how we approach treatment of these patients. 2017, in my opinion, was probably the biggest shift in AML. And I think 2017, for a lot of us, was a very exciting year for AML. And I think it's the first time we really see the needle start to move. And we really start to see more treatment options shift and for the betterment of our patients. And that's because the focus was less on how do we move the deck chairs and make treatment a little bit better, and rather shift our focus in how do we start looking at leukemia differently, how do we start treating it differently, and creating better options for our patients. So this is a slide that I love to share, and I think this really highlights that last statement, that if you look at new drug approvals in the past 7 years, in AML, remember November 1973, in the past 7 years, there have been 11 new drugs approved for AML. And to me, that's incredible. I think that's an incredible advancement. Really, the credit goes to everybody involved, but most importantly, the patients that help us develop these regimens. But 7 short years, we've seen a huge shift. And so I want to really spend the next part of the talk just kind of going over some of the regimens that are more common. I recognize that there are a lot more out there, and I really just tried to slim it down to make it palatable. So the first, and one that I think a lot of us have a lot of experience with, is azacitidine plus venetoclax. This was the New England Journal study published by Courtney DiNardo and the Anderson group, really looking at the phase 3 study of azacitidine plus venetoclax versus azacitidine single agent. They looked at patients who were unfit for chemotherapy based off of either age or comorbidities. They did include patients with an ECOG up to 3, and they enrolled 431 patients. And if you look at the age range, they included patients up to age 91. That's pretty incredible and really sparked a lot of ideas for people. Primary endpoint in this study was overall survival. And you look at this combination, azacitidine plus venetoclax, when compared to azacitidine single agent, there was an improvement in overall survival. There was an improvement in complete remission rates at 66%, almost doubling HMA alone. There were rates of febrile neutropenia that were slightly higher, although less if you compare it to 7 and 3 and some of the other regimens. And 10% of patients in this trial went on to receive a stem cell transplant. So this is a very effective regimen and has been now explored in many different populations, but this was a publication of the phase 3 study. There's also looking at our 7 and 3 regimen, but CPX-351, which is a liposomal form of cytarabine daunorubicin, looking at it in patients, again, highlighting that older age range population, 60 to 75. They did include people with an ECOG of 0 to 2, and they compared it to standard induction 7 plus 3, looking at overall survival as the endpoint. And you see here the study did meet its primary endpoint. There was an improvement in median overall survival. There were higher rates of remission, and also if you sparse out the 60 to 69 and 70 to 75, you see comparable remission rates, which were highlighting that this is a very effective regimen in patients with secondary AML. There were higher rates of febrile neutropenia if you compare it to cross-trial to other regimens, but actually slightly better than what we see in 7 plus 3. And 34% of patients went on to receive transplant from this study. Here's a forest plot really kind of highlighting that group. Again, older patients, secondary AML, seem to benefit most from this combination, if fit enough. The next target, when we look at targeting therapies, is ivosidenib in IDH1. This is really an exciting trial as well. The AGILE trial looked at ivosidenib plus azacitidine in newly diagnosed patients with IDH1 mutated AML. This is a publication, of course, of just the phase 3 study. It included patients with an ECOG of 0 to 2, median age of 76, and again, highlighting they included patients up to age 84. They looked at ivo-aza versus azacitidine alone, treatment for at least 6 months, and then looked at primary endpoint of event-free survival, which they defined as no response at week 24, relapse, or death. And it met its primary endpoint, improvement in median event-free survival. There was also an improvement in overall survival, higher rate of CR, and I really like that they included this as well in the study, an improvement in quality of life for these patients by going this route with Ivo-Aza. Excuse me. There were lower rates of febrile neutropenia as well, which I thought was interesting in this combination. So I think this is really an exciting one. Discussion of which regimen to go with up front still, I think, is sequencing, I think, really matters, and I think that's a topic for a whole nother discussion. In IDH2 mutated AML, there are some exciting advancements. I don't know if we're fully there yet, but I think that there are some interesting studies out there. So the AG221 AML-005 was an older study, looked at enasidenib plus AZA versus azacitidine alone. We did find that there were higher rates of response rates and higher CR rates. Unfortunately, that didn't translate into improvement in overall survival or event-free survival. And it seems like one of the biggest problems with this combination was really the cytopenias. And if you look at the cytopenias between both groups, it probably more relates to the biology of IDH2 mutated AML because they were comparable between enasidenib and AZA versus azacitidine alone. So then it led to this more recent study, which I think is interesting. I think it's thought-provoking. But they basically looked at giving patients enasidenib single agent, and this was a phase 2, 1B study. This is the more recent publication from it. Looked at patients that had newly diagnosed IDH2 mutated AML, and they got 5 cycles of enasidenib single agent. And they looked at the monotherapy, and if there wasn't a response by 5 cycles, then azacitidine was added to see if you could further that response and potentially avoid some of the cytopenias that happen with azacitidine. And again, they included patients up to age 89. And what we found was that there was a really good response rate, CR rate of 48% with just the monotherapy. And then for the 17 patients who didn't get into remission, then adding azacitidine, about 41% of them were able to get to remission with this combination. And you see here transplant, eventually getting patients to transplant was a very effective, about 10% of people, and then 13% of people when azacitidine was added. So I think this is an interesting approach. Again, I don't know if it's answered all of our questions for IDH2 mutated AML, especially in the newly diagnosed setting, but gives us one option. FLT3 has been an exciting area. This is the initial trial that I think a lot of us are very aware of, the RATIFY, which looked at 7+3 adding in midostaurin, midostaurin being a type 1 FLT3 inhibitor used in both FLT3, ITD, and TKD mutated AML. This was a very effective regimen, met its primary endpoint. The problem is the initial ratified trials, they only included patients up to age 60. So there were left a lot of questions about what to do in patients older than 60 with a FLT3 mutated AML. There was a follow-up study to this, the AML-SG 1610, that looked at patients in a similar patient population, but shifted now the needle up to age 70. So they included patients up to age 70 and looked at event-free survival. They used propensity score weighting analysis to compare it to historical controls. And what they found was that in older patient population, so even the ones above 60 to 70, there was still that improvement in CR rates, and you see that 72% of these patients went on to receive transplant, 34% continued maintenance therapy, and so there was an improvement ultimately with event-free survival, especially in this older age range, which was great. More recently, we have quizartinib, which is another FLT3 inhibitor, a different FLT3 inhibitor. It's a type 2 FLT3 inhibitor. And the Quantum First was recently published as well, looking at 7+3 plus quizartinib. This is, of course, the publication of the phase 3 data. And this trial was set up to include patients up to age 75, where they received induction, consolidation, plus minus transplant, and then went on to continue 3 years of quizartinib maintenance. And the primary endpoint here was event-free survival. So we do see that the study met its primary endpoints. There was an improvement in overall survival and benefit also to those who went into transplant in CR1. So I think the quizartinib data is very exciting. In patients older than 60, if you the post hoc analysis split it out, 60 to 75 range, there still seems to be a benefit, although not quite maybe as great as the under 60, but still I think a very effective regimen and one that we use at Ochsner as well. Looking at some more less intense therapy options, and I think this is an area where we start to really incorporate some of the biology and try to look for synergy between drugs and focus on the biology of the disease and how do we make it more effective. So azacitidine plus venetoclax, now adding in gilteritinib. And this was a study led by Nick Short and the Anderson group. It was a phase 1-2 study, and there were patients both newly diagnosed and relapsed refractory, and they included patients up to age 82 with an ECOG of up to 0 to 3. And so you find that the response rates were really effective, 96% CR, and they were deep and durable. So almost everybody, so 93% of patients were able to achieve MRD negativity, and then the 18-month overall survival was 72%. 4 patients went on to receive transplant. And then, of course, in the relapse refractory setting, 75% of patients achieved CR. So I think this is a good combination, a very effective combination, but really requires appropriate titration. I've used this regimen before and really requires a lot of titration to get people through it. An interesting abstract from ASH this past year, similar idea, similar concept, looking at decitabine, venetoclax, and quizartinib. They included 50 patients, and what I loved about this trial was they looked at patients primarily in the relapse refractory setting, and you see here 85% of patients received a prior FLT3, 40% had a prior allo transplant. And even in this relapse refractory setting, patients that had seen a FLT3 inhibitor before, we still see about 70% of patients achieving CR with this combination, so I'll be excited to see more of where this goes. So my favorite topic of discussion, Dr. Finn knows, I could probably talk for hours about transplant alone, transplant in this age range, in this age population. And I think this is an area that, in my opinion, has been incredibly exciting nowadays with more effective ways to prevent graft versus host disease, more effective ways at selecting donors. Transplant has really, in my opinion, opened a lot of doors for patients, and we've seen a lot of really exciting results. So if you look at the NCCN guidelines, patients older than 60, consolidative therapy, I highlighted in red for everybody to enjoy as much as I do that allogeneic transplant is considered in there for all of them. Of course, in the favorable, maybe not so much, but intermediate and adverse risk, older than 60, yes, we can transplant. Yes, we can transplant. I often get the question of how old, and I think that's debatable, but certainly the BMT-CTN data, if you extrapolate from that, the BMT-CTN 1102 looked at transplant in MDS. We did see that there was an improvement, not just in overall survival with transplant in MDS up to age 75, but also an improvement in quality of life, which is shocking for a lot of people, probably even the investigators in the trial, but I think transplant, and to me, sky's the limit. So if we would like to look at some trials, well, I just wonder how many you want to look at, because I have included quite a few here. And we have a lot of trials really showing that transplant's not only safe, but very effective for this age range and this great group of patients. I think, to me, this is an area that is often underappreciated, as we've seen so many wonderful advancements in the treatment of AML, but people are forgetting that the transplanters like myself are behind the scenes really excited about the advancements that we've seen. And it's led to some questions, and one that I personally have a lot of thoughts and ideas about and excitement for, is if we can potentially, with all of these new targeted therapies, are there ways of getting people through some sort of induction therapy without toxicity, get them into transplant, and focus our efforts on that maintenance piece of the puzzle that we don't have a great answer for yet. So this was Keith Pratt's in the group published some retrospective analysis of patients from the Viali trials, looking at those who got HMA or LDAC plus venetoclax and went on to receive transplant, which included about 10% of patients. And you see here 55% of patients were able to achieve maintain remission at 1 year, and even 40% of those patients, and granted small numbers, but 40% of those patients were alive for over 2 years, presumably cured. And so I think that this really started to spin some wheels for people and led to this publication from the Anderson group as well, both Nick Short, Uday Palpat, looking at retrospectively 127 patients older than 60, and they looked at patients who went on to receive transplant, whether they received intensive chemotherapy or lower intensive therapy with or without venetoclax. And as you can see here, very much surprising and exciting is that the long-term post-transplant outcomes were very good. And the most important thing is regardless of what kind of induction they got. So whether we blasted them with induction, heavy intensive induction chemotherapy, or they got less intense therapy and got to remission, those who went into transplant in first remission had comparable long-term outcomes. What I think is really impressive is the bottom curve. You can see the patients who received less intense therapy actually had lower rates of non-relapse mortality. And that really kind of highlights something that I've really been thinking for a while is, again, if you can get people safely through induction, get them into remission without developing renal failure or lingering infections or other comorbid conditions that play into leading into higher rates of non-relapse mortality, do we see better outcomes? And I think that this study, for me, was really exciting, and I think that there's certainly more to come. This was a retrospective analysis, but it gives me comfort also in some patients that if they're kind of borderline saying, look, we can go with maybe more of the less intense therapy, get you to transplant and see where it goes from there. So some exciting new targets. I'll just talk briefly on this. I think there's a lot of room for growth here, but the first, which we all think in this room have probably heard about, are menin inhibitors, a new pathway for targeting in leukemias in KMT2A rearranged leukemia and NPM1 mutated leukemias. It's very exciting. There are a lot of new menin inhibitors. I'm really pleased that we are going to have one of the menin inhibitor trials at Ochsner very soon, any day now. We're excited because the prelim data has been very exciting. And so I can't wait to see as these unfold. A couple others that I think, I don't know if we're fully there yet, but just to highlight a couple other pathways, looking at APR-246 and magrolimab, an anti-CD47 antibody. I think there's still some, obviously, room for growth here and development, but there are a lot of trials, and hopefully we can see some more data coming out as new pathways are discovered. So I'm going to close with two final thoughts. The first, and I think most importantly, is the question of what will the next decade look like? And I think, when we look at the curve here on the left, you see the improvement in younger patients. But again, I think I've highlighted a lot of the really exciting things that haven't yet caught up to the data that we're seeing here. And so I really do hope that the next study to come out looking at the next decade will see the curves on the right looking more like the curves on the left. And I do firmly believe that with advancements in transplant and managing leukemia and better ways to sequence therapy, we will start to see that. And I think this is an exciting time. Again, 2017 has been the opening of Pandora's box for leukemia people like myself. And so I'm excited to see what will happen. And then the other thing that I told Dr. Finn I forgot to include in my presentation, this is a topic of advocacy. So highlighting, again, my interest in transplant, recently this summer working with Julie Stokes and Senator Gary Carter, we're excited to announce that here in Louisiana, we're able to pass some legislation that will add Be the Match, or now NMDP, to all of the DMVs across Louisiana, with the goal of really recognizing that here in Louisiana, we have a very unique patient population. I say the diversity in the state is incredible regardless of listed ethnicity. And I think that probably highlights the gumbo of people of what make up our patient population. And I find that really our unrelated donor options here in Louisiana are much lower than they are in other parts of the country. I looked at our numbers from Ochsner past 3 years, and we do about 15 to 20% unrelated donor transplants, which is significantly less than we see in other parts of the country, and it's not because we're not looking. We do a majority, over 50% of our transplants are haplo or half match. And so I'm hoping with this recent legislation that just got passed, it will enact in July of 2024. So this July, be looking out for it at all the DMVs. That will increase the diversity in the donor pool that we have for our patients here in Louisiana, but also for patients across the country. And so I really am a firm believer in advocacy for what we need for our patients here in Louisiana, and appreciate all those that helped us get there. So with that, I'll stop for questions. Let's see if there are, at the end, sorry, at the end.